Mr. Gallagher? Here. Mr. Schron? Mr. Schron is absent. Ms. Brown? Here. We have a quorum, and I'd like the record to reflect that Ms. Simon is in attendance.
Thank you. Is there any public comment related to the agenda?
No, Mr. Chair, none is signed in.
It's a 16 meeting. If there are no objections, I'll make a motion to approve the minutes as presented. Motion's been made and seconded. Any discussion on the motion? Hearing none, all in favor signify by saying aye.
Aye.
All opposed? That motion is adopted. We have no matters referred to committee. We have one item for discussion, and that is the county's hospitalization and regionalization self-insurance fund. And obviously this has been an issue that's been communicated through the media, and we've all received phone calls and issues and received questions regarding the initial purpose, as I called the meeting, was to understand where we are, how we got here, and what the plans are going forward. So I don't know if it's Director Kennedy or Director Keenan, Director Dykes. I'm not sure who's going to lead off, but the fundamental question is, how is it that we're projecting a $9.5 million loss?
Mr. Chairman?
Yes,
Quick
Mr.
before you started, did we get responses back to the questions that were submitted?
We did, and the answers, I have the answers. Do you have the answers?
No.
Mr. I'm sorry, no, we did not get, I'm sorry, we did not get answers. They were going to be presented to us today.
Indicate those.
Yes.
Is it morning? Good afternoon.
It's after, yes. Sir.
So how would you guys like to
Well, let's do
have
this.
Do you
Yeah.
want to go over the questions first, or do you want to go over
Why don't we do that? Why don't we start with the questions? Because council
Okay.
submitted a series of questions collectively that were presented to the administration. So why don't we do that? And so we have the email
Okay.
from Mr. McAleer from September 29th, and it is broken down into two major categories: finance and HR.
Okay.
So why
I'm
don't we
gonna
start with
ask-
the finance side?
You want to start with the finance
Yeah, let's start with the
side?
finance side, because obviously, the operational side, the HR side will come out as a result of some financial questions.
Good afternoon.
Good afternoon. Thank you for coming. So why don't we just go ahead and start. Obviously, we've got 7 finance questions that the council members had submitted for answers.
The first question was to provide a brief explanation as to what accounts for the projected $9.5 million deficit on the county self-insurance fund. Additionally, explain that is the revenue side versus the fact that expenses are actually coming in less by about $2 million. Expenditures are projected to total $97 million in 2016, which is $1.9 million less than the budget. This includes not only medical, but benefits administration, regular insurance. Those are the ancillary items such as life insurance, dental, and vision. The $9.5 million deficit represents the difference between the current revenue and expenditure estimates.
So if what you're saying is the expenses were how much under budget?
1.9.
1.9. And so then if we're saying that if expenses are under budget 1.9 and the on the revenue side, so then we're saying revenue then is off by 11.4 million, 9.5 plus 1.9.
If that were based on the budget, so if we're looking just at what we're projecting for expenses, that's where the 9 million comes in. And it's revenues less than what we need to cover the expenses.
And so in the budget that we approved, and comparing it to the second quarter projections, and we have a schedule here, a small table here, and I don't know if you have that. It's just this table. We basically just extrapolated, our staff extrapolated out the budget versus projection numbers. So the budget for the self-insurance fund was, I'm just going to round, was $88 million in revenue, and the second quarter projection had $79 million, obviously $9 million less. Happened between what we thought was going to happen when the budget was compiled and what actually happened. Obviously, there must be some modeling that was done that said, okay, between each of the plans, we expect X amount from Medical Mutual, X amount from Metro Health, and then that obviously was different than what we actually experienced. So where was the difference?
So Two things. First of all, the budget is done before open enrollment is completed. So they're always going to change a little bit because we don't have real data on who's going to be in which plans. I think we had a lot of people migrate to the Metro plan in 2016, which means we wouldn't have generated any revenue from them. Also, when we did the budget, we assumed that the rates employer and or employee would be increased to cover the expenses. Self-insurance is an internal service fund, so we allocate 100% of those costs. So that's why our budget, the revenue and expenditure numbers would have matched. And the rates weren't increased.
So are you saying when the budget was compiled, the budget assumed an increase, but there was no actual increase? And what was the budget increase projection? Or what was the percentage of the anticipated increase included in the budget? Meaning,
I don't know what the percentage would have been, but it's to get to the 88 million. So I think by the time we were doing the budget, we would have known that the employee rates weren't changing, so the employer share should have increased, and it didn't.
Okay. So it wasn't necessarily, because there must be at least some actuarial data or at least some practical data that says, okay, when we have open enrollment, there's a movement between the different options. So did you see a significant amount of movement between one plan or the other that caused a portion of this deficit? Because obviously I think we're identifying the fact that the deficits on the right, kind of what I'm trying to ask the question. So if the revenue to a shift in plans, that's one thing. But if it's also due to the fact that during the budget, revenue would go up, and then what actually happened was revenue did not go up.
Right. And I think that's the larger of the two. So HR can better answer the question on who migrated to which plans, but I think we did have a migration to the Metro plan. I don't know how much revenue generated from them.
But a large portion of this issue is the fact that the budget anticipated an increase in revenue, and what was actually realized was not that.
Right.
Okay. Any question? Mr. Miller? And then Ms. Simon.
On the chart, on this, the hospitalization, is that our own fund as opposed to the other?
That's the county plan.
And why is it?
Wait, I'm sorry, Mr. Miller. Do you have a copy of this?
No.
Here's, or Chrissy has one. Sorry, I just wanted to make sure, Mr. Miller, they were working off the same document.
Right. And the regionalization and the hospitalization plan, why is it that even the initial balance is significantly different on the Q2 projection as opposed to the budget? It would seem that the beginning fund balance would be a pretty constant number. Could you explain that?
Not at the time the budget was approved. So the budget was approved in December, which would have been prior to the end of the year.
So the budget was approved in December. So then after the end of the month, with a month or so later, we got the year-end numbers. Mm-hmm. So we're talking of a difference of 2 months or so in those time frames. Is that about right? Mm-hmm. What happened to change the balance by $8.5 million on the hospitalization and by over $10 million on the regionalization?
So column 1, the first column, beginning fund balances, where Mr. Miller's talking about.
I don't know. That would just be a reflection of the bills that were paid.
I would like a little more research to be done on that, and for you to get back to me, because that's a large shift over the from the time we approved the budget until the time we got the year-end numbers. The balance in the hospitalization fund went from 12 million 186 to 3.5 million, and it went from 11 million to under 1 million. So I'd like to get a better understanding of why that occurred.
Okay, thank you. Ms. Simon?
Follow-up, thank you. So this deficit or alleged deficit was anticipated at the beginning of the year then, when you saw all the migration to perhaps Metro. And when I read the Plain Dealer article, it said it was just discovered. So this should have been anticipated at the time, and maybe this just dovetails the questions that came from Councilman Miller. If there was a sense that people were migrating to different plans and the revenue was going to be deficient, why now are we saying that we just discovered this?
I can't answer that, but I know in the projections that we've been publishing all year, we've been reflecting the shortfall.
So is one of the shortfalls in perhaps in the regional plan a heavy claim, the reserve in that, and that this is just a snapshot in time?
The claims were substantial in both, but I don't have all the specific claim information. Perhaps HR or somebody from Oswald would have that info.
So if we looked at the historical data on this, or are we just looking at this particular period in time where claims were high?
This isn't a snapshot, so our estimates are based on, we do some historical analysis and we work with our consultant based on the rest of the year. So we're not looking at it as a.
Different if the claims aren't going to continue at this pace.
Absolutely,
Right,
absolutely.
okay. I'll let you go, Mr. Chair.
No,
but
if you have another question, continue.
It's
Okay, Mr. Schron.
It sounds to me as though if it's on the revenue side, the Metro pricing, is that an issue that, was it priced correctly to get the revenue? The intent is, on most self-insurance programs, is to be having revenue exceeding the cost expenditures, and to have a reserve build up to cover contingent claims. It doesn't look like either one of those were done here. Where was the pricing set for the Metro?
So the Metro participant, well, that's probably better for HR to talk about the rates, but the Metro participants don't pay.
No, I understand that. But the pricing to which you're doing your calculation is what your multiplier is.
The problem is that we should have been charge it back to the individual agencies. We should have increased that, and we didn't.
And the same with the regional to third-party plans that were brought into this also. Is that correct?
Right, but the regional rates would have been fixed, so that's not a problem. We could have corrected by increasing their rates this year.
And where did the regional rates get fixed? By whom?
HR.
That's a decision based on. a
Account.
No, that's
consultant.
not, that's being done by the outside consultants or bringing that rate recommendation to HR.
They make recommendations.
Right.
It's recommended.
And what is the status of that provider as far as the information? It's been replaced, has it not? That consultant is no longer on board.
Correct.
Yeah. And so when we were pricing that product in from the very beginning, based on claims experience, did you folks look at it all from an actuarially third party?
There was an independent actuarial report that's provided as required by contract. So I know that, at least with respect to EBI, that they had looked at that. I know that that report was also made available for Oswald, I believe, as of the end of 2015.
Wasn't it early on that we were getting some harbingers of things that this was already an incorrectly priced product from the third party? So we knew full well that our product was priced incorrectly, more than likely, from the consultants who were telling us that, and we chose to ignore that.
I can't say that for last year. I can only say for based on our projections this year, that we are seeing now based on the activity that it looks like the revenue is not coming in where it should to cover our expenses.
Okay, so revenue based on an insurance product can only come from two sources of calculation, the head count and the dollar count.
Correct.
And it's highly likely that we could have been forecasting, as the consultants were telling us, that the head count was going to move towards a non-contributory plan, not exactly rocket sciences. And if we didn't price it correctly, this was the only result we're going to get, was a shortfall. Because that's what we were being told, that's what the consultants were saying.
Well, a deficit would also be affected by the level of claims coming in our expenses.
By the claims, but not at this short time. The claims experience, most of that, because your claims experience is based on your actual claims and then a reserve for future potential contingencies that are going to develop as a result of a cancer or anything like that.
Well, it's actual claims plus incurred but not paid.
Right.
And then a provision to be set aside against your reserves for any.
When you go back and look at
Extraordinary
the planning and the advice from the consultant at that time, does it look as though they were correct in the warning signs that they were giving us? That we were underpricing, the product was going to have, that we were going to get to this place?
Which consultant are you speaking of?
The first ones, the initial ones that were then replaced.
I don't remember even being part of the process to see the recommendations for those rates.
I can't ask you to respond to something you didn't
I
see.
wasn't,
but-
yeah, I wasn't a party to any of those conversations.
Yeah, there were some warning signs being given to a lot of folks on that regard to that. Thank you.
Ms. Simon? Okay, we'll go to Ms. Simon, then Mr. Miller.
So what's your projection for the regional plan for the end of the year, surplus or deficit? And what is your opinion on what, if there is a deficit, what that is? Because from our calculation, it's not 4.5 million.
So currently, we are projecting that the regional plan is likely going to break even. We're not projecting a $4.5 million deficit.
Okay, so this 9.5 deficit then that was reported to the Northeast Ohio Media Group then, I thought included a regional plan deficit.
That's the county plan.
It's only the county plan, it's not the regional plan.
Right.
So the regional plan is right now not gonna, it's gonna break even.
That's what we're projecting.
Okay.
Second quarter, we were projecting a deficit for the regional plan, but the revenue's been coming in. I
Right.
think people were late in paying. but
Okay.
We've been seeing more revenue come in. So I'm saying right now, I think they're going to break even.
Okay. And secondly, with regard to Metro Health, if I recall, wasn't there a renegotiation of a contract with Metro Health that happened that might impact the rates? No?
I don't know. That would be a question for HR.
Okay, because I thought there was a renegotiation of rates with Metro Health, and I'm not sure that your calculations are including those new rates that were negotiated.
If I could just ask you to speak, just speak more to the microphone, I'm
If
sorry.
those rates were in effect at the beginning of the year, then our calculation should take them into court because we're basing this off of actual activity.
Okay, we'll follow up with that. Thanks, Mr. Chair.
Okay, Mr. Miller? And just a reminder, we're still on question 1.
Couple things where it says on the second column under hospitalization, it says available resources 82,525,000, expenditures 89,812,000. So why is the ending balance not minus 7.3 million instead of minus 11.4?
Oh, that was,
Okay.
yeah, Mr. King put this schedule together, so.
That would be, if he's taking it from, so if he's taking it from our fund schedules, that the difference is carryover obligations. So we have contracts in effect. The difference between the 11 and 7 would be what we expect to be paid next year on this year's contracts.
Okay, and it also says budgeted beginning fund balance reflects the 2015 beginning funds, whereas the Q2 projection beginning fund balance represents the 2016 beginning funds. So that might explain why those numbers are so different.
This is what we talked about? Yeah, it's right. So the $12 million, that was the beginning fund balance in 2015.
Uh-huh. And then the 3,576,000, that was the beginning balance in 2016.
Correct,
So that could explain why those numbers are so different.
correct.
Okay, okay, thank you.
Okay, so just to sum, and I'm focused, I'm just looking at the hospitalization, the county's own plan, because I'm still trying to understand I understand how the situation happened, I understand what's going on here. Basically, there was there was a number put forth in the budget of $88 million. That it had an increase, an assessment, an assumption of an increase in fees, which didn't happen.
That's correct.
And so, and then we had some folks plan to another, which had an impact as well towards lowering the revenue coming in. So it's a combination of those two things, but the belief is the larger component of that is I'll go this way. The smaller component is the switching of the plans. The large component is the fact that the recommendations presented in the budget of increasing the revenue was not actually put into place.
That's correct.
Okay. And that in itself is 10 million, I'm around roughly $10 million. And if I'm extrapolating that, assuming everything else works out, if it had been put in place, then at least in the hospitalization fund, there might be a slight surplus. Just looking how the math plays out.
That's correct.
And that's what you're saying in the regionalization plan is if I move down the same ideology down into that one, I heard you say to Ms. Simon that there was a belief that the regional plan might not be, maybe closer to break even.
That's our
than a
belief
loss.
now.
Okay, but it wasn't earlier. You thought it was trending negatively, but now
Right.
based on revenues coming in and because
Right.
we're cash basis, not accrual, we have to record what comes in and how it comes in. What's the belief on the hospitalization plan?
I think we're still assuming about the same. I think now we're looking at maybe a $7.5 to $8 million shortfall,
Okay,
but it's close to what we were projecting in second quarter.
okay.
We are going to be increasing the employer costs though, so the deficit will be eliminated prior to the end of the year.
Okay. So we're increasing the revenue for the self-insurance fund, which means we're increasing our expenses as well,
Right,
correct? Because it's an internal
Right.
internal function.
right. 40% hits the general fund.
So the net impact to the bottom line of the county is zero because you're increasing one revenue fund by offsetting with an expense fund, but by an expense account. But at the end of the day, the self-insurance fund will be increased in its revenue
That's correct.
to offset this. Okay. So it looks like, kind of getting back to, I think Ms. Simon was touching on this, this was not necessarily something new in the sense that whenever the decision was made not to increase the revenue as presented as represented in the budget that was presented, then we knew then at that point that there was going to be a revenue shortfall.
That's correct.
Okay. Any other questions on question one? Okay. All right. Thank you. If you want to go on to question two.
Question 2 was at the time the 2016-2017 biennial budget was approved, the estimated revenue for the county self-insurance fund was $88 million. At mid-year, the second quarter report had an estimated revenue amount of $78 million. Please provide details to why the $10 million is less now than what was assumed at budget time and what is included in these revenue figures. Also, please explain how these revenue estimates are developed. So we basically touched on this already. Do you want me to?
No, unless there are further questions on it. And I think a couple more of these we've touched on as we went through the first answer. So we'll go on to the third question. And if you don't mind continuing story time, just because
Sure.
there are folks in the audience who don't have the questions.
What are your revenue and expense projections as of today for both the county's hospitalization and regional self-insurance funds for 2016? And that same question would be applicable for 2017.
I believe you briefly touched on it, but is there a little more elaboration, or do you think we've covered it well enough?
For 2016, the estimates for the regional plan are roughly $38 million in revenue, $35.3 million in expenses.
$2 million of that revenue, though, is a reserve from the board obligated to have a $2 million reserve.
Right, they have a little different, if my colleagues remember, when we approved their regional partners.
And that's reflected in that number.
Okay.
And for the regional plan in 2017, the revenue would be 43 to be 40.7.
So that difference, then the anticipation is will assist in building up the reserves?
That's correct. Those numbers are likely going to change, though, because we haven't been given the 2017 rates for the regionals yet.
Okay, Ms. Simon.
So why is there an anticipation to increase the municipal partners' rates significantly that doesn't reflect what you're stating now with regard to the expected revenue and expense? Euclid has, I think, been told that their rates are going to increase substantially beyond this projection. I don't understand why the cities are being hit with up to 20% increases when we're seeing at worst a wash and perhaps a carryover reserve.
So for 2017, based on the
Maggie, I'm sorry, Director.
recommendations from the consultant, we are assuming, I believe, a 9% increase in expenses just for inflation. And then we're also building in a reserve, which we should have in both of our funds. So that would be reflected in the increase of expenses, which means their rates would have to increase to cover those expenses.
So what are the reserves now in the regional plan?
We don't have a reserve. We have the $2 million from the, but that's it.
Okay. So I'd like to see the breakdown of the consultant's recommendation as to why we would need to increase it by this great of a percentage to the communities. And I'm not sure that the projection in terms of inflation and what's calculated is going to justify that type of increase to the cities that rely on this regional plan and came in good faith. And now they're being hit with astronomical fees. And part of why we started this plan was to be able to support the communities. And I don't see that there's a reflection necessarily between what's being asked for as an increase and what I'm seeing here as a projection. So I really need that nailed down percentage-wise. So I know you can't do it now.
Well, and directors, plural, what is the anticipated timeline to have a more definitive, concrete plan as to how these addressed?
We have the rates for the county plan, we just don't have the rates for the regional plan.
Okay.
I don't know when
Okay.
we're
Yep.
estimated.
Ms. Simon.
Just one more question. Have historically ever reached a 9% inflation level? I don't know where that's coming from. I don't recall hearing that historically as an inflation level. It's any year. Why? What's the basis for this?
So that, I hate to punt, but I think is a question for HR, because we in fiscal really only see the actual expenditures, which could reflect timing of payments. So if we were late in paying bills one year, the next year we'd see a huge increase, which I think is an indicative in actual claims costs. HR would have that information. I don't know if we've ever seen a 9% increase.
And if I recall, we did see that there was a backlog in between 14, in general, some of which were RX, were prescription drugs. I remember specifically there was a huge shoebox somewhere with unpaid bills that was held at the end of 14 to be paid in 15.
I believe that was an occurrence that happened more than once. I think it happened in 2013. It seemed when we first started looking at it last year that the county cut off paying the bills somewhere around October. We made a pretty concrete effort last year to pay everything through the end of the year. If you remember, we amended those contracts towards year end, and I think that was part of the last minute council meeting at the end of the year, but we made an attempt to match the incurred claims with the period, and I don't think that was being done for the
13 and 14, in one of the, I believe it was in 14, maybe it was 13, we actually paid 48 weeks worth of expenses against 52 weeks worth of revenue. As a finance guy and a cash basis, you do that to make your numbers look better at the end of the year, recognizing that the next year you're going to be paying 56 weeks worth of expenses against 52 weeks worth of revenue, which is what happened, I believe, in 15, correct? That was the year. It was 14, and then it was in 15 we had more weeks of expenses because there was, like I said, this fictitious shoebox of unpaid bills that were deferred in payment until the next year.
correct.
Okay. Any other questions, Mr. Schramm?
Yeah, following up on Ms. Simon's comments, do you know if the cities received substantial reductions in their rates when they came and joined this plan from where they were currently paying?
I don't know the answer to that.
Outside of discussions I had with people in some of those participating entities, that was the basis for them coming to the county plan, that it was considerably less than what they had received in their own quotes, but I don't have any information, any kind of empirical information to back that up.
Okay, if we could check that out, because it's my understanding is that cities like Euclid received a substantial reduction to join this plan, and that they were being told that this was unrealistic reductions from people within the market. So I don't know whether there's any truth to that. And then when this comes to fruition, should they be shocked when there was, is it appropriate? Probably not, but should they be shocked when we do see increases to cover certainly a self-funded program? Do you know of anybody who does a self-funded program without reserves? Does that make any sense?
I do not know.
No, I mean, that makes no sense, does it? I mean, because you don't even know a cancer claim that is diagnosed today could have a phenomenal increase in cost, and if you haven't reserved for that, it's just an unrealistic self-insured program.
We should have a reserve, and the 2017 budget will reflect the buildup of our.
Questions that should have been, I believe, asked probably when anybody joined our plan. What are your reserves? How do you, and to me, those are pretty just basic questions that any consultant should have been providing them. And I thought they had consultants in regards to this, most of these folks who joined our plan. Shame on both parties for not doing this correctly, because it's just not the way you take care of cancer claims and things of that nature without reserves out there. Thank you.
Ms. Simon.
So I don't believe this was unrealistic. I just have a question. I mean, if we're breaking even, there's no unrealistic projection of what the premium should have been for municipalities if it's a break even. And we did have reserves in the past. I think it was just because we had an uptick that. So two questions. I mean, is this unrealistic to have a break even plan?
I think we should have, the problem with regional is there is no reserve. So theoretically, we shouldn't be breaking even. We should have more revenue.
Okay. So we had reserve in the past though on the regional plan.
We did, so I'd have to look to see what it was in the past couple of years. I know we started the year with 800,000, which isn't much on a $35 million plan, and we're breaking even, assuming we're gonna draw down that 800,000.
So, and my question again is the increase in the rates in municipalities may be far in excess of what we need to do to establish a reserve. And that's the question I have. And I don't know. I mean,
For 17, you mean?
yes.
That's a question for either HR or the healthcare consultants.
Okay. Mr. Miller.
Mr. Chair, Director, you said that the 2017 rates for the county plan have been set. Would you describe what those are, how they differ from the current rates in effect?
I would probably leave that to the HR folks to give you the details on that. I do not have the details about the changes in the plan.
Okay. All right. We'll add that to the HR side.
Dave?
Mr. Schron.
I know you keep kicking the ball over to the HR on some of these issues, but you are who we look to from a financial standpoint on this. And if you were building a financial model unrelated to HR, because you have the ability to look backwards at least 3 or 4 or 5 years of experience and say, okay, what would be a good percentage of reserves? 0 is obviously not an acceptable reserve, and be having in that
The
range.
recommendation is, the minimum is 14%.
Right.
The recommendation is, I think, 21 or 23%.
Right, so therefore, to be trying to catch up to put that in place is an appropriate thing to be charging for every member. The fact that somebody got off with a lighter bill in prior years doesn't mean that that's the appropriate bill that they should have received from the beginning. Is that
That's correct. And we're looking to build up the reserve over 3 years. So it's not all going to be hit in 1 year.
understand. But the objective is to move all the way on up from 10 to 14 to probably into the 20 range so that you can cover catastrophic claims out there.
And so that we're in compliance that are related to our audit and some other.
We look to you folks to do the financial modeling, and if the two of you disagree, then this body ought to be the one to say we're going to err on the side of one or the other, either on one side that maybe is lighter or one side that might be heavier in regards to those kind of questions, because that clearly is putting an obligation on future boards as to how they fund these things. And we're having this problem because it's a revenue problem primarily.
Yeah, Mr. Schron, I was just responding to Mr. Miller's question about the breakdown of the differences between the plans. I do not have that with me. I assume the HR folks do have some more detail on that, either from their own records or for the consultant.
And from the standpoint of a 9%, we're not talking, I don't think, about the cost of living increase as it relates to hourly wages. We're talking about the cost of living increase as it relates to medical with any other cost of living. Is that?
That's correct.
Yeah, and because the medical device, the medical property liability, and all the other. Thank you.
Mr. Chair, one follow-up.
Ms. Simon?
So I don't think we can sit here today to say that the increases in the municipalities, Euclid per se, is a direct correlation between what needs to be increased to achieve the 14% to 20% reserve. That's the question. I think my colleague's assuming that that increase to Euclid is going to be necessary to reach the 14% minimum reserve that you're striving for. And can you sit here today to say that the projected increase to Euclid is going to be necessary to achieve this goal of the reserve?
I haven't seen the rates for the municipality, so I don't know what their increase is.
So we don't even know necessarily that the rate increases are going to be necessary to reach the goal of the reserve. And I think my colleague's making that assumption, but I haven't seen it and you haven't seen the rate increases. So who can speak to that?
I would assume that either HR or the consultant has the rate detail. I know there's been meetings with some of the regional entities. We were not involved in those meetings.
Okay. So that's, I think I asked for it and I'll get that, I suppose, from the consultants or HR today. We'll be able to measure and correlate the proposed rate increase to that which is necessary to have this objective goal of a reserve. Okay, thank you.
And I think one thing to remember too is the consultant this year did an individual analysis of all the regional partners to come up with individual rates that they propose for each one of those entities, whereas in the past, it was looked at as a consolidation of all the entities, and they all received the same rate increase. So here, there is a variance between different entities as to how much, if any, their rates are going to go up. I don't know what those rate increases are.
Okay, but I'd like to see both. I mean, I don't see why we would not have a collective analysis as well, to have a pool, just like NOPEC or any other collective pool, to be able to assess the overall plan instead of just focusing in on individual cities and perhaps making it prohibitive for them to be in this when it comes out. At least at this point, as a neutral outcome. But so I'd like to see the consultant come up with both ways to analyze this instead of just going to each municipality. Because the whole point of this was a regional plan.
Well, why don't we do this? Because I think those questions are great questions, but they're probably more geared towards the HR side of this discussion. Okay. All right. Just moving on. We've probably touched on numbers 4, 5, and 6, at least to the extent that 6 can be answered. Number 7 was, were you able to provide, or I'm going to ask you, were you able to put together a 10-year historical average? Number 7.
We were, and we do have those charts available. That's on a cash basis.
Okay.
Again, just to consider, I don't know if you want me to read the rates or if we send that to the committee.
It might be better because I think my colleagues are very much interested in hearing from HR. If you can ask any questions off of those reports. Okay. Any other questions on the financial side of this issue? No. So just to summarize, it just appears that what was presented in the budget as far as anticipated revenue was not the actual revenue that was collected. Realized.
That's correct.
Okay. And coupled with a small shift in plans, but that's anticipated revenue.
Right.
Not being implemented.
Any shift in the demographics would affect the plan, particularly if more people are going towards the cheaper entity.
Right. Okay. Great. Thank you. Well, let me ask, any other questions? Okay. Hearing none, then thank you, and we'll.
Thank you.
So just for the record,
I'm Douglas Dykes. I'm the Chief Talent Officer.
All right. Thank you. So I hope, as Ms. Simon said, you were taking notes on some questions that came up as a result of the previous presentation to answer. But let's just go ahead and start with with the 6 questions that were presented prior to this committee meeting.
And if you don't mind, I think you have a text because we did provide it to Joe Nani
There's
last week.
We have, is this the document you're referring to?
I can't see that far.
No? Okay, I don't know. Mr. McAleer or Mr. King, do you?
Mr. Chairman, Trevor McAleer, council staff. Yes, on, I believe, Thursday or Friday, HR sent us individual cities breakdown of proposed rate increases for 2017. So we have each city in a separate
Okay, can we?
PowerPoint.
I didn't see that in our, it's in the in this PowerPoint?
It's not in that PowerPoint, that's a separate, that's a,
Okay.
I think, a general overview of the regional plan, not specific rate increases. We provided that one, but the other one's probably about 30 pages or so. If you want that for discussion purposes, we can print that out.
Yeah, I think it's germane, especially since the director led with that. So would it be possible to have that printed out?
Yes.
And we'll move to another question. Is each page? like,
Each page is by city.
Yeah,
And so it has current rates and proposed 2017 rates, and then how many individuals within that city are on each plan.
okay. So there's no summary document, it's individual pages.
So the original email has a summary. I think for the purposes of our discussion today, that the email that I sent on Friday has the overview. The attachments are the breakdown of it's kind of an overview of claims or for you to look at on your own.
Well,
But
let's start with the summary, and then if we can have that resubmitted to the members of all members of council, so they have that document as well. So, yeah, would it be possible at least to get the summary printed?
Yes.
Okay, thank you. So, Mr. Dykes, is there another, that's where you're going to lead. Do you want to continue to discuss that as we're in anticipation of receiving that schedule, or do you want us to wait a minute if
That would be great if we
All
could
right.
wait so you'll have the information. There's a lot of numbers on it.
Okay.
So.
Well, Mr. Dykes, why don't we do this while that document's being retrieved? Let's go ahead and skip down to number 3. The consultant is not here, are they?
No, they are not here today.
Okay. So if it's consultant project, the expenses will go up for 2017.
So, and if I could, I want to get to your question, but I also want to take a step back. Chief Dykes is going to pass out the sheets that will show you the new rates, specifically for the internal county plans. And I believe Trevor's going to get you the overview for the regional partners. But when we look at, there's been a lot of conversations talking from people moving to the metro plans, the regional program breaking even. We also talked about reserves, rates, how they were set, things like that. And I think bottom line is it's a culmination of everything. So I want to just take a minute to draw that picture before we get to where we are with the rates today, if that's okay. So first, talking about the metro plan, we can't say that just at the end of 2015 there was a huge convergence to metro. Metro enrollees converted over time. So when the metro plan was originally started, it was a free plan, and our employee population enrolled in a number of different plans: Metro, UHC, and Medical Mutual. As time has passed, employees are starting to jump to Metro, but I just want to draw that picture. This didn't happen all at once. So with a free plan, as more and more employees were jumping to Metro, we could sustain the costs that were coming in. But one of the main problems that we're seeing today is as new employees come on board, they're also going to Metro, but the health of our population is declining. So although the free plan originally allowed us to maintain costs, we had the appropriate budget and reserves
Let
in
me
place.
just interject. When we say free plan, we're not talking, it means that the employees are not charged a copay or.
Yes. The county is paying for the cost of the plan. The employees are not paying premiums.
In our other plans, it's a 90-10.
Correct.
It's where the employee pays 10%.
There's a
So when we
number
say
of-
free, it's not, it's free, there's no
Thank you for the
cost to the
clarification.
employee, but there's still a cost, an expense to the county.
Yes.
Okay, all right.
So the employees, as you indicated, employees are not paying any of the premiums for the cost of that plan. So one of the issues as the population under Metro has continued to build, they're experiencing one or more chronic conditions, which when employees are not paying any part of the premiums, the county is paying for all those costs. And it's not unique to Metro, it's our entire employee population. So I think it's important just to point that out, because as we have met with all of our healthcare providers, there's a common theme that as you look across there is a large number of our population that has 1 to 4 chronic conditions that they're dealing with. And so that is driving a large amount of the claims. And as you guys know, being a self-insured employer, we're paying for those claims. So as we talked about the rates were not set to offset what we're paying in expenses. And so as we continue to have employees who are experiencing high claims, have multiple chronic conditions, and overall there's a general lack of preventive care and health care, preventive care that's going on to maintain those chronic conditions or improve them, we can't offset the expenses that are coming in. And that's across the board. And as we have spent a lot of time sitting down with OBM, we do look at these programs as different. Yes, holistically, it's a regional program, but we do need to break these into 2 separate items, the county plan and the regional plan, because they're 2 separate beasts. They really, we have an overall shortfall, but when we look at them 2 separately, they are 2 very different things. So I just went over to Metro. It's happened slowly over time, and our employee population has a number of chronic conditions that are driving up claims. Overall, rates were not set correctly. Through the audit that was done and through continuous audits that we're doing, we're trying to figure out where the breakdowns occurred, not necessarily to point out. And we have had our new consultant on board, Oswald, sitting with both departments just to dive into where are we at, how did we get here, and how do we right-size the ship so that we don't continue to experience these shortfalls. We are still working through, digging through all the layers of documentation to find out why they were wrong, what the recommendation was. I think during the initial conversation, one of your questions was, what were the recommendations? Who said them? Who agreed? Unfortunately, there was some turnover, and a lot of those key players aren't here to answer those questions. So we just need to figure out how do we fix this moving forward and make sure it doesn't happen again.
Well, wait, I'm sorry. There was maybe I'm incorrect. Was there I thought there was a transition period as one was leaving, one was coming in. Is that correct?
And my understanding is when the former consultant was terminated, the current consultant was brought on board for a temporary period under a separate contract until they were fully implemented as the new healthcare consultant. Is that what you were referring to?
At no point was the county ever did not have a consultant on board, correct?
Correct.
And at one point there were 2. I thought there was an overlap. I thought Oswald was brought in to provide some advice while EBI was still under contract.
Yeah, so Oswald, when I got here last year or the beginning of this year, Oswald, we were using them as the, they weren't actually on contract from what I understand.
But they were advising.
They were advising at that point, yes.
And EBI was still here.
And EBI was still here,
Okay.
yes.
So there was continuous advice consultation provided to the county. At one
Yes.
point, there were two groups.
Yes.
Okay. I thought I heard that differently, and I just wanted to make sure that was my recollection.
So I apologize. I've only been here about 5 months. I've been spending 5 months diving in, so there may be things that
Sure.
not quite up on, but when those come up, I'll defer to the appropriate parties. So in addition to the rates, just looking at one of your questions earlier was how did we not see this coming, and just looking at the financials and projections. And one of the things that we focused a lot on as we built this regional program, the regional partners are paying, to be part of the regional pool, but there's a lag from the time that they join the regional program to the time that we start receiving claims for them. So when you look at that, on average, there's going to be generally a 3-month lag time. And so as we look at the budget from 15, money's coming in and offsetting some of those expenses, but we're not necessarily getting the new claims and expenses for the regional program. So we start to see a little bit of an upswing in the budget, and it's covering any of those shortfalls or things that we should have seen coming because we have money coming in from these regional partners. And so it took some time to get here. And I think to Mr. Kennedy's credit, and when we're talking about this, is that it really took some digging to look into this and say, wait a minute, something's not right. Because again, we had some money coming in from those regional partners and not enough is going out because we hadn't received their claims yet. They call that the incurred but not received expenses, and that's just typical for healthcare. It can take anywhere from 3+ months to actually see claims start rolling in.
Well, and it's a timing, cash flow timing difference.
Absolutely.
Okay.
So I think once that started to catch up, that's when, things aren't looking right. We're starting to have some concerns about budget. So, and even talking about some of this, when we talk about shortfalls, and we've been meeting a lot with all of our unions and our management teams to talk about kind of the state of benefits. And when we talk about these shortfalls, they're being paid. The county's paying the expenses, but it's not money that was designated from our self-insured budget. It's money that we're pulling from different areas to offset those shortfalls. So as we've talked to everybody, we say, okay, yes, the important thing is the bills are being paid, but we're offsetting that from funds from different areas that weren't set forth for that self-insurance fund. And so I think that, to me, when I was diving into this was important because when you look at some of this, it's like, oh, wait a minute, it doesn't make sense. You're right, because we're paying the bills. We're not going, they're not going unpaid, but we are pulling it from different areas that wasn't designated necessarily at that moment for the self-insurance fund.
So the county had a poor history of not paying its bills on time, especially its prescription bills. And there was a period of time where we were challenged in being able to, the vendors were challenged in continuing to provide a service. How far back, where are we on the aging of our payables to our vendors? Are we on time? Are we getting any more that we're not paying our bills on time?
I don't believe so. I don't know if you were receiving any notice on that, but I believe that's been resolved.
Okay, thank you.
So in going into that, and I know talking about inflation in the last few years, and just to talk about the inflation, it's looking at things like just increased medical costs overall. I mean, talking about prescriptions in general, prescriptions have skyrocketed in prices. So inflation is building from a number of different things, from general cost of services, office visits, preventive care, MRIs, you name it, it falls in there. But even just looking in general, I think prescription coverage is an easy one to identify. That just looking back 10, 15 years ago, what you paid for a prescription is, 3, 4, 5 times what it was. So when we look at inflation, those reflected inflation numbers are estimates based on those increased cost of services. I don't know offhand what they've been trending over the years, but it is something that we can pull. All right, so number 3, I believe was where you started. What are your revenue and expense projections? I'm sorry, that's the finance one.
So number 3 was, what does the benefit consultant project the expenses will go up for 2017?
So the projected increase is 5.5% overall, and that's assuming that the $9.5 million revenue item is made equal. So without the changes, the overall increase, it's in excess of $14 million revenue.
That's on the revenue side. What about expenses? You said five and change on expenses, and the balance is is to replenish the reserve.
Correct. So we have built in a $3.8 million reserve over the next 3 years. So that'll add up at the end of the 3 years to put us to an adequate reserve amount to maintain moving forward. There was a lot of discussion earlier about the reserves and how we've determined the rates, and again, the offsetting of the claims and expenses that are coming in. Those reserves were pooled and used to pay off the claims, and we just haven't stabilized to a point where we can replenish those reserve funds. So I think Maggie pointed out earlier, in addition with these rates, we're looking at building a $3.8 million over the next 3 years to fund that reserve account.
That's 3.8 per year?
Per year.
Okay, Mr. Miller.
Are we now talking our plan or regional?
This is our plan.
Okay. You're projecting a 16% increase in revenue.
Correct.
So we're talking generically about reserves. Obviously, there's a provision that talks about in state law about how reserves are to be calculated. So have we conferred, or has Oswald conferred with an actuary to ensure that these are the appropriate reserves?
Absolutely. That's where the number came from, the 3.8 over the next 3 years, each year. It came from an actuarial representative that works with Oswald.
So it's per year? Okay. I'm going to make just a generic statement, and you folks are new, so I'll give you the benefit of the doubt. I hate getting information at a meeting and being asked to provide commentary on it. So in the future, please present this information far enough in advance so that we have it to review. Because otherwise, I'm inclined to end the meeting right now and call you back in a week, because I don't like doing things this way.
Appreciate that.
So we'll give you the benefit of the doubt right now, but in the future, please present information in advance. Ms. Simon.
Thank you, Mr. Chair. Please don't close the meeting down before I ask.
No.
My only statement is I don't think we've ever seen a 9.5 inflation figure, and I'm very skeptical about where that's coming from. And this council is going to be looking very closely at this because it's going to impact the regional rates. And are you treating each city as an individual pool now versus the whole regional pool of partners?
So it is a collective risk sharing pool. But when we're looking at the regional partners and what their rate's going to be, it is based on a number of items, including.
You did it before, is it? Maybe you don't know.
No, it wasn't. How it is.
So who's making the decision now to do it this way when we are breaking even right now with this regional plan, and now we're going to do something differently? So each city then is impacted differently when the whole intent of this plan was to have a regional pool together and adjust rates accordingly. Who's making this decision? Is this the consultant that's not here?
It's the consultant that's recommending, and we did accept his recommendation.
But
And
council was never asked whether we wanted to do it this way. Council's the one that approved this regional benefit plan from day one with the new government, with the goal of assisting communities be able to survive. And this isn't hurting our county if we're at a break-even point, and now we're going to adjust things differently, which I think this council needs to weigh in on if this is how we want to proceed.
And I can appreciate that, Councilwoman. I will tell you that, the best thing I can do is draw an example. So if there were regional partners that decided that January 1st, we're going to go out on our own, we have a lot of expense from a lot of the other, or some of the regional partners that they're not paying what they should pay. And although we will be at a break even at the end of the year, within the first 2 months or 3 months of the new year, we will be at a significant deficit. I mean, I have one regional partner right now that the claims that what they've paid is around $219,000, and that's through the 7 months of this year. And their expenses is around $270,000. So that's where we'll be. And so I do understand that, the council wants to be involved, and we'll provide you with that information. But
questioning whether a particular municipality is going to have an influx of claims at a particular time. The question is, how are we going to determine what the rates are and treat this pool? Is it going to be a collective risk for everybody in it? And this isn't how we're doing this. We're doing it differently, and my position is the council was never asked whether we wanted to change this way we've been operating, and it's going to impact our communities, and we represent these communities, and we're the ones who are going to be there to represent them. So this council needs to be involved in how this is going to be determined. And I appreciate the first 3 months, the first quarter of next year might be high, but by the end of the year, it might be different. So maybe not. But all I'm saying is I'm not sure that this council, and I'm only speaking as one, I'm going to represent my communities, and I want to be involved with my colleagues on how we're going to determine these rates and how we're going to assess these pools.
understood.
Mr. Miller.
Mr. Chairman, Ms. Woods, can you explain how the 16% revenue increase in the county hospitalization fund is being achieved? Is the county budgeting more? Are we charging more to plan participants? What are the changes to make this happen?
So the answer to your question, Chairman, is yes, all of the above. We really have to look at all of, and I believe Mr. Dykes has provided you with some rate sheets, but there has to be adjustments in the percentage of premiums paid, co-pays, how much the county themselves is putting in for revenues to offset some of those costs. One of the things we've been talking very heavily about to the regional partners and our unions is the idea of implementing a wellness program to help offset some costs. As you drive wellness at the county, you hope to get some controls on chronic conditions or just management of health alone and focus on well-being. And so there's a lot of things that go into this. To answer your question, it's all of the above.
And what portion of it is on the employer side and what portion of it is on the employee side?
So the majority of it to put, as we look at our plans, starting with our Metro plan, just looking for next year, employees are paying 3% of the plan cost. The rest is being paid by the county. And that's a change going from, again, employees paying 0% of the premiums to 3%. Looking at our other programs, they're anywhere from a 1090 to an 80/60 plan. I'm sorry, an 80/20 plan. So the healthcare costs that are the premiums that our employees are experiencing are very low. When you look at, on average, other agencies and the premiums, they're ranging anywhere from 15% on up to 20 and 25. So, while it's painful to see increases, it's also unheard of to see employees paying 0 to 3% of a premium cost. I would like to, Councilwoman Simon, just to touch base, I think Mr. Dykes and I would both agree that one of our focuses on how we increase communication up front and make sure everyone understands and on board with where we're going in the future. So I appreciate that. When we look at the regional plan, when I get the budget correct, we would have had to implement a 24% increase across the board to the regional partners. Now, what that means is any of the regional partners that had low claims experience or, very low costs, even if they're individual, if we did a 24% across the board, everyone would have to take in those expenses that are coming out. And so as we looked at the regional program and just looking at individual entities, City of Euclid, Fairview Heights, individuals like that, if their claims experience and their loss ratio came back and said, well, they should have a 9.9% increase. we didn't want to impose a 24% to have everyone offset the costs of our others.
Mr. Chair, I guess this is for a different discussion, but I don't understand where this 24% is coming from when we are break even and don't have a deficit. At first I heard there was a 4.5 million in the regional plan. Now I'm hearing it's not, and I'm hearing there's a break even. We definitely want to build a reserve. So I'm unclear about where you're getting these numbers. If it's some projection for the first quarter next year, that's not something that's going to necessarily be the sustainable rate. So this is a different discussion. I just don't know where these numbers are coming from.
Sounds good.
Well, Gallagher, then Miller.
I would have to piggyback. Decisions are being made here, and partners don't treat partners like we've been treating these partners. And you're new, and you came on, and things changed, and we were you. And you took the recommendation of somebody that we hired to change the game in the middle of it. And I understand changing the game, but you can't change the game in the middle of the game. Now, going forward, I could understand if they knew going forward their numbers are going to be high, they're going to be charged high. So we have some people that are pretty upset, and justifiably so, because if you've ever done a budget, especially with cities, especially with small cities or organizations, it blows the budget. And I'm with Ms. Simon on this. This cannot stand as is. Going forward, I'd understand doing it as long as they know. They didn't know this was coming. We blindsided a whole bunch of folks. So I think we need to have that discussion at another time before letters are again sent out to get people in a bind wondering if their budgets are blown.
We can do that.
Mr. Miller.
I'd like you to amplify a little bit on something you said earlier about the health of our population is getting worse, and we're not doing very well about prevention, and that we're the chronic diseases are not being properly taken care of. That there's a whole lot of one of the features of the national healthcare system, its advantages and disadvantages and being what they are, but one of the good things was supposed to be that that preventative care is covered, and hopefully people encouraged to participate in it. And my question is why aren't we doing better, and why is the health of our population getting worse?
So there's a couple of things to that. One, I agree with healthcare providers and having their annual physicals. The healthcare providers are sending out information and helping with preventative care. But you also have another population that don't engage in a physical, that only go to the physician when they have to, when they can't get out of bed or when things get really bad. So while there has been a shift to preventative care, we're only reaching part of our population. And that's why many agencies, you're seeing the spike in wellness programs, because that's one way we can help get controls in place and really drive our population, especially those that aren't going for their annual physicals or engaging in that preventative care, to truly do that. So that's one of the plans, is to re-implement the wellness program and look at driving that culture from within. It can't just be the health carriers, it has to be the county. And when you create a culture that's focusing on well-being, it's focusing on driving physicals and health risk assessments, and then not only driving that, but then what you do with the information, that's when we can start to truly try and get a handle on some of those healthcare costs. So just looking currently, and this is talking about regional and county alone. So 48% of all of our members have at least one chronic condition. 48% have at least one chronic condition. Members with one or more conditions account for 87.4% of total payments. 52% of the population had less than 13% of the total spend. So while individuals with chronic illnesses represent nearly 50% of the total population, less than 4% of those same individuals are actually engaging in chronic condition management. So that's where we have to target some of our efforts. And our goal is to implement a wellness program at the first of the year to start driving some of that.
So you're saying only 4% of the people with chronic conditions are engaging in management?
Correct.
One thing that I would, one problem with the physicals is that they stir up so much stuff and do so many things that don't amount to anything. I think this scares people off. So there needs to be some separating out what's really a serious problem, current or potential, and what doesn't amount to much. So I think that's one of the problems we have with this.
Agreed. And one of the things we're doing during our open enrollment this year is really focusing on education, how to be a smart healthcare consumer. And that's one of the pieces that we're focusing on, asking questions when they refer you for a test. Why? What's it going to do? What's the cost? Is it covered? So we're really going to focus a lot of education to help employees because it can be very overwhelming. And we want them to be comfortable going in those things to challenge, ask questions, understand their options, and then utilizing our county HR department to help them through that process. So education is going to be a large piece.
Okay, Mr. Gallagher. Oh, did I miss you?
Couple times.
I'm sorry. All right, sorry.
I was just going to ask, years ago, it was probably 3 years ago, we were in discussions, and at that time I brought up people that are smoking, and I would imagine your stats are showing most of the people that are providing us with high claims are smokers. Other people have done it. I don't know why we don't do it. You can cut them out if they want to smoke. They're killing us. They're blowing our budget, and that's a personal choice. And I don't think that personal choice to drive up our costs. And it seems to work other places. Is there a way to identify the cost of smoking in these plans?
There is, and as we talk about this and just looking at over the past 6 to 8 months, looking at our options for the healthcare plans, that's absolutely one that we've explored. What does that look at? There's a lot of options available, and I think as we move forward, especially with it, I want to tie it back to this wellness program again. A wellness program is a mechanism to help employees quit. It provides smoking cessation piece so that as we look at where we go in the future, that may be something that's there, but we're going to start first with let's help you quit. Let's help get these changes. And then if you choose not to, where does that go for your healthcare rate? So it's absolutely something that we're going to look at over the future. But again, taking into consideration, that's a huge culture change. It's a huge shift. And you're right, it has a big impact. As an employer, we want to make sure that we're helping offset that with programs to help people quit if they want to.
It is, and I know, and I understand that tobacco is a horrible thing to get off of, but we're in the real world now discussing dollars and cents, and it affects everything. And I think maybe as we go forward, as you say, probably a smart thing is to go slow as opposed to quickly. But I need to start. Thank you,
Okay, Mr. Sharon.
agree with my colleague on it. It's hard to justify a habit that kills people from our standpoint, from that standpoint. But national average as far as participation, what would it be in the private sector as far as in your insurance premiums? What percentage?
I'm sorry, could you repeat that?
Your national average that people would participate in helping, because this helps drive activity. We all know that. What's the national average as far as participation in a claim? You were at 3% here before we just introduced it. What?
15, 20%.
Just give me your range.
So you're looking at 15, 20%.
Right. That's
Yes.
I knew that, and so what we're saying is, if our revenue is going to go up 16% based on the model, if they're now finally asking for 3%, that means that the county is picking up 15.5%. We just want to make sure that everybody hears that real clear, that is not being transferred to the individual, they're picking up less than 0.5% of this 16%.
Yeah.
Which is really shocking in relationship to all the rest of the world when they're paying 15 to 20%.
Yeah.
It is just an unrealistic place to be. When my colleagues talking about cigarette smoking, this is also an unrealistic place to be. 4 years ago, when we were having these first conversations, I brought up HSAs. They are truly a driver of saving and participation. I don't still see any conversation about HSAs. Our last consultant talked about they were going to introduce it, and they kicked the can down every year we had these discussions. I don't see anything being discussed now unless it's someplace else in the picture.
So you bring up a good point, and this year, when we developed the premiums for the current Metro plan at 3%, we're also implementing an HSA. And so employees who want to maintain the zero premiums, it will be in a high deductible HSA plan.
Okay. And what are we contributing anything into the HSA then?
No.
We're not.
Okay, so it's 100% out of their pocket?
Correct.
Okay, so that they're essentially, we're contributing the 3% we would have gotten but for, because one's getting it and the other one's not.
Correct.
So we really are contributing 3% into their HSA. If one side is getting it and one side's not, if one side's being asked. Now, I understand it's a different program, but a healthy individual will, their HSA account will generate thousands of dollars for them to hopefully to go on in the future. As far as, I know my colleague was talking about the shock on the plan to see these increases. I'm even more shocked to think that we were running these things without any form of reserves. That is really for the good of the 1.3 million people in the county. I'm sorry that there's going to be some communities that are going to get a shock, but if they really were doing their homework, and I know they had consultants, Euclid had consultants, all these folks had consultants when they came forward and made these switches. That's a question that somebody should have been asking. What are the reserves? What percentage of my self-insured premium is going into a reserve pool? And if no one asked that, shame on them as a community, because they weren't doing their homework. Because I know that they were being told that all this information. The Affordable Care Act, obviously, major insurance companies are leaving that all over the country. It must be a reason why that's happening. Can you give me your best estimate? I can only assume its claims experience is running at a higher rate than what the revenue experience is.
Let me do this, just because I don't mean to.
Yeah, I just want to.
I'll rephrase. Is there a correlation between the ACA carriers, what they're seeing and what we're seeing?
Yes.
So don't be shocked when we see it in our own home.
Gotten all the data on that yet, but our consultants and other consultants have said there is a direct correlation. We don't have any numbers for you today on that.
And we took money for 3 months from people like Euclid without a claims kicking in for those 3 months, and we didn't reserve those 3 months worth of premiums. We used them to pay Rob Peter to pay Paul, it sounds like to me. Please respond.
Yes.
Thank you.
Okay, I have just a question, then we'll move back. Keep referring to a wellness program. I know the county had a wellness program. I believe it was just discontinued at the beginning of. They're talking about is retrospective activity. What makes us think that a different wellness program is going to achieve a different result?
So it's all in how you implement the wellness program, and you're correct in 2015, because we needed to do a deeper dive in the state of affairs and figure out the best way to.
No wellness program, then to continue one that might be moderately successful in lieu of nothing?
So I'll speak just from the information that I've learned, from the research, but the issue with the previous wellness program was there wasn't anything driving prevention. again, the true benefit of a wellness program is to drive wellness and well-being. And so the previous program was kind of a check the box. Did you get your physical? Did you go to an event? And did you do a few other things? And if you did, we gave you money on a card. It doesn't drive wellness. A good wellness program drives, did you do this? But now what are you doing with that information? So if you were told you had high blood pressure, if you're obese, if you, any number of things, what did you do to do that? Are you going through preventive care? Are you engaging in some nutrition? Are you, and that's where you see a value of a program, not just paying people for showing up, but an incentive to drive lifestyle change. So to answer your question, yes, it was believed we needed to stop it because at that point we're just handing out money. We're not driving lifestyle changes, and it's got to be a balance. To show true value of a program, we've got to drive well-being because that's how we get a control on our costs.
And let me add to that too. When I first came in and I saw some of the programs that we offered, or as related to our wellness program, it really wasn't tied to the chronic conditions that it should have been tied to. We were rewarding people for watching videos. We were rewarding people for sitting in a lunch and learn. But again, it wasn't tied specifically to the chronic conditions that we've been talking about since we got up here. Okay. And so we stopped it and said, we're going to do this right. And we're rolling out one tied to chronic condition management in 2017.
Okay. Okay, we'll go to Mr. Miller, then Ms. Simon.
What are the major chronic conditions out there that need to be managed?
Yeah, that list.
I do not have the list with me, but it is, we have seen a number of claims with cancer, diabetes, high blood pressure, obesity, and we can give you the trends. I don't have them with me, but those are some of the general areas that we're seeing.
Okay, thank you. Ms. Simon.
Where are you going to get the parameters for this new wellness program? Is that from the consultant?
We do it together.
Together?
So we will have a wellness consultant on board, and it will be a very collaborative approach. It will have care consultant, and then we've also an employee assistance program.
Well,
so,
I recall Dr. Esselstyn from the Cleveland Clinic speaking live to our employees about the benefits of a no-meat animal product diet, and that goes directly to chronic conditions, if not employees. So I'm not sure when you say that we did not have programs that directly related to chronic conditions. I don't think that's true. Are you going to be addressing diet?
Is that we did not have a focus on the chronic conditions. So our wellness program in 2017 geared towards those chronic conditions that's driving our cost up. It came to chronic condition, but the focus of the program wasn't specifically for the chronic conditions. I mean, I saw some of the programs and they just weren't related.
That program will probably be better discussed in human resources. So I'm sure Chairperson Conwell would be welcome to have that discussion. Let's move back to the questions because we have about 27 minutes. No filibustering allowed, so let's move through them. Let's go back to number one. So do you have a 5-year historical look back? Now we're talking about the employee, the county program of the rate increases by year.
yes, so that was one of the handouts that Chief Dykes provided for you. It's labeled at the top 5-year historical look back on employee rate increases. It's a lengthy document, but you can see from 2009 to current year, the percentage increase for each plan.
Okay. Can you just...
So this breaks it down by category, union type. So I'll start with CSEA. Since 2009, they one increase in 2016, that's 2%. All the other previous years were 0%.
Okay.
Increase from 13, 14, 15, and 16. Another AFSCME union, again, 2%, 13 through 16, 1% increase in 12. CCOMS group, 2% increase starting in 13, 14, and 15.
Thank you.
Airport 2% starting in 13 and 14.
Let me, we don't have to, I didn't realize it was this, I didn't have it in my package, but
Okay.
I see it now. And there's no reason to go through all 4 or 5 pages.
Okay.
And these are premium increases for the employees, is what we're saying here.
Correct.
Any questions? No. Okay. All right, so we have that information. Thank you.
One question, Mr. Chairman.
Yes, Mr. Harrison.
And so these
Mr.
increases are, I'm assuming negotiated, when we're bargaining, correct?
I don't believe they're negotiated. The union contracts speak employee pays, but not the increase amounts.
But not the increased amount. So are we, for the labor, the unions that, next year, I believe, about what, 85–90% of the, will be doing bargaining with most of these units next year, come 2017, correct?
We will be doing some
So
bargaining,
are
and I will check on my previous response.
Okay, so, all right, so are we holding off on implementing these increase in the percentages until we return to the bargaining table next year? Or are we gonna go ahead and throw these at them before that time, instead of waiting until we go back to the table next year, seeing that it's only 2017, which is a few months away?
We are moving forward with implementing them. We have met with all of the business agents. We have one remaining union that was unable to attend the meetings, but we have provided them with a presentation and discussed the increase of the rates.
Because of these rates, these steep rates, that, the hikes that we're implementing, $20 a month can blow a person's budget. 1746 looks to have the largest amount of individuals who will be impacted by these increases. I believe many of which, 70%, are about African-American women who are single mothers who are head of households. And so when we begin to talk about implementing rates that are high as the ones we're hearing about today, that makes a difference. And that is the part that I'm uncomfortable with, that we're throwing these rates of individuals, things that we've known about for months, and we come right before open enrollment period, we slap in the face with this. This is a problem. And just add that, not involving us, once we decided to make the change on how we implement, or how we, even with the regional partners, the program that we have there, to skip into another subject, not including us in that conversation, I don't believe it's correct. I think that this council who created that regional, who supported that regional program to be implemented, that we be not consulted, but involved in that discussion as we move forward. So as relates to the county plan for employees, non-union and union, that we slowly, we do this slowly and not just throw this at them immediately like this, or at the very least, once we go back to the bargaining table in 2017, that we use at that time to implement these increases. I understand you've met with them, but I'm sure many of them have concerns, just like I do, about who's being affected and to what extent.
Okay, understood.
Okay. Mr. Sharon.
Maybe I'm missing something, but 16% increase we're talking about in the revenue is not being shared by the individuals, at least they're using Metro. Is that correct, other than the 3%?
Correct.
Which is less than a half of 1% of the 16.
Correct.
So 15.52 is coming out of the taxpayer's pocket directly out of our general fund. This is not coming out of any insurance actuarial account.
Correct. And we did.
We're not passing this along. Contrary to what my colleague just said, this is being absorbed by the taxpayer. Is that?
Yes,
Thank you.
correct.
I'm sorry, restate that, please.
We just, at least I believe, heard that on the Metro plan, we are now for the first time going to be charging 3% of the premium. Therefore, of the 16% increase, that represents 0.48% of the 16.
Mm-hmm.
In other words, 15.52%, if I'm understanding the math, is going to be 100% of the taxpayer.
Okay. All right, thank you. These sheets and looking at them, these are all with bargaining units. What about non-bargaining employees? What have their increases been?
It's the same.
The same as,
Your sheet marked at the top 2,000 revenue and expense excluding.
talks about the rate increases, look back rate increases. What non-bargaining rate increases?
This is the look back.
Yeah, I will get back to you, but I believe they are included in here, so I can provide a follow-up to break down the specific names of these agencies so it's clear.
I'm not sure I understand what you just said. These are bargaining units right here on this sheet of paper. So how are the non-bargaining unit employees included in these?
That you're looking at is the 5-year look back sheet.
Didn't say bargaining, it said employees.
I know, and that was a mistake on our part. We will get you that, to look back for the non-bargaining.
Okay. All right, the second question. Did the current or previous benefits consultant recommend any rate increases for 2016 for either the regional or county benefits side? If so, who made the recommendations? How much was the recommendation? How much of the recommendation and how much ultimately was the increase that may or may not have been implemented? So there are a couple questions in there, but they're all related.
So yes, to answer your question regarding the recommendation from the previous consultant so far as increases, we are still, and again, we're going through a lot of information in a short period of time. We're still trying to figure out why those recommendations weren't moved forward with. We don't have that answer right now.
Okay.
We are still looking into it.
Okay. Any questions? Okay, number 4, 3 we've answered. 4, assuming current projections show a deficit in 2017, explain how the county plans to correct the deficit in 17 and beyond. So we might have already kind of touched on that, but just.
So we are moving, looking to move benefits to market levels, and so when you do review the overviews, we are making adjustments to the CERB Ohio averages, as well as investing in areas where we can improve the health of the population, as we discussed. So our claims are largely driven by the chronic and catastrophic claimants that I talked about earlier. Reducing the impact of their conditions not only improves our healthcare expenses and also reduces absenteeism, but it will impact just general quality of life. So you're correct. We talked about a lot of those and are moving forward looking at wellness will also have an additional impact.
Question 5, assuming the county plans to increase employee rates at some point in the future, is there a plan to phase in rate increases over several years to mitigate the impact on employees?
So absolutely, we do have a 5-year plan to phase in increases, as well as phase in new discount opportunities for employees who qualify for the health incentive plan. As we talked about, we will look over the next 5 years at things like tobacco surcharges, spouse surcharges, these are looking at. So we are taking those in consideration in addition to the incentive plan under the wellness program.
Okay, and then the last question here, as my colleagues have more, given the timing of open enrollment, which typically occurs near the end of a budget process, how can the county more accurately project revenue when putting together a budget?
So we have been working collaboratively with Oswald as well as OBM, and through Oswald, they do have modeling software, which is very common in this type of practice, to predict the impact of movement within the plans. So even taking into consideration rate increases, they have software that'll help with that predictive modeling so we can anticipate those expenses. We also need to use a more conservative approach when we're rating the programs to ensure we're considering how the health index of the population may change that.
So when the 16-17 budget, was they not use modeling as a predictor for future premiums? Somebody had to, right? I mean, EBI was no longer engaged. I think at that point, county had somebody advising. Was it Oswald?
It was Oswald, and
yeah.
and I will ask them that question. They did not use the modeling that they're talking about.
And then the question obviously is the modeling they used, what was used by OBM to create in the employee plan, the $88 million projection. And then obviously we're still trying to identify why the budget anticipated increase was not implemented.
Right.
Okay, so, okay. Any other questions? Mr. Sharon?
Where would the authority have been to make that decision to not implement the recommendations as far as the pricing recommendations from Oswald or anybody? There should be a piece of paper with somebody signing saying that I chose not to move forward with recommendations.
I'm not 100% sure who, but we will find that for you. Yes.
Somebody needs to be held accountable for that decision as to why we have the shortcoming.
Okay.
Ms. Brown?
Mr. Chair, I just want to clarify by Councilman Shrine. So the employees, are you saying the employees' rates are not going to go up?
They are going to go up. I don't want to speak for Councilman Schramm, but I think he is drawing the distinction that the overall increases are being funded from the county budget, which is coming from our taxpayers. So while there is a 3% increase to their premiums, when you do the math, it works out to, and you did the math much quicker than I could, 0.48. So to answer your question, they are getting increased. Metro alone, they'll be paying 3% of the premium. You have two handouts. They're titled 2017 Medical Program and Related Revenue. And that lays out the individual employee monthly costs as well as the total cost overall. So Metro alone, the monthly cost for a single employee for monthly Metro is $14.62. A family plan under the Metro is $38.02. And total cost, yeah.
What about the premiums? Are those considered the premiums?
They are.
Okay. Mr. Chairman. Thank you.
Yes, Mr. Miller?
I would just bring to your attention that when we did that calculation about the impact on the Metro employees, that, as I understand it, employees are going to pay is being applied to the entire cost, not just to the 16% increase. Is that correct?
It's 3% overall, correct?
Where previously they paid nothing.
Correct.
So it would probably be more accurate to say the employees will pay 3% and 13% of the increase will be paid by the taxpayers. I mean, it's still small, but it's not 0.48. It's they're being asked to pay 3% of the total cost, where before they paid nothing.
Okay. Mr. Hairston?
Just one last point. I know you mentioned that includes the premiums, but I'm sure there's deductibles associated with that also, correct? And what are those?
You also have in front of you a handout that provides the overview of copays and deductibles for all three of our plans. It's titled Cuyahoga County Regional Health Plan. It looks like this, and that breaks down each of our plans.
Yes, so many.
Yeah.
Okay. Yes, Ms. Brown.
I'm sorry. And this is probably to the chairman's point. It makes it challenging to get our questions out accurately, and when we only had a little time to review the document. So the Metro Health, how do we find the current copay versus the new copay versus the old deductible versus the new deductible? Because that's where my question, and I think Councilman Hairston's questions lie at the moment.
Sure. So again, looking at this handout that I provided you, the second column just on page 1, it says current Metro Select. And then on the right, you see new Metro Select Premier proposed and new Metro Select HD, that's the high deductible. So current Metro Select, those are the current copays and deductibles, and then the
In the second
proposed.
column.
Correct.
Okay.
And the 3% plan and the high deductible plan. And then it goes on the same on the other pages. You'll see the current program and the new program. Left is current, right is the new.
Deductible is, can you,
It's all the way on the right, on the front page, new Metro Select HD. The HD stands for the high
so where we
deductible.
have the primary care physician office visit where it's a $20 copay, and then the DED, then 20%. What is DED?
Deductible.
Deductible.
So under a HSA, they have to reach their deductible before the contributions take place. So DED stands for deductible.
Okay.
It's a high deductible HSA.
Is that what Councilman Schramm is also speaking about with the health care spending, or no? Is this something different, the HSA?
It is the HSA plan.
Okay, all right, thank you.
And this is $2,500 for a single and $5,000 for a family.
That's correct.
Wow,
It's a high deductible HSA.
it is. Okay.
It's lower than our current high deductible plan, but it is.
So, Mr. Chairman, I assume
Yes.
that we're going to want to further discussions at another time.
Yes, and what I was gonna suggest, I have yet to see the council agenda for next Tuesday's meeting, but if there are items referred to committee in that agenda, then I want to bring the answers that we're waiting for, those discussed. It'll also give us an opportunity to review the information that we were presented here today. So there will be a follow-on meeting. It would depend on a couple things, but there will be definitely a follow-on meeting. And if you can get those answers either to our clerk or to Mr. McAleer, that would be helpful, and then he'll disseminate them to us.
Will do.
All right, thank you. Any other questions? Okay, hearing none, moving on the agenda until we receive the answers back from the administration. Thank you.